Welcome, everyone. We are so glad that you've joined us this evening and looking forward to a great panel. My name is Dr. Naina Harawa. I am a professor of medicine and epidemiology at UCLA and Charles Drew University. And I'm here as a director together with Dr. Ayako Miyashita Ochoa of the Policy Impact Core for the Center for HIV Identification, Prevention, and Treatment Services. And we are just getting started as people join in the room, but we've got a wonderful panel for you today that includes people from the UCLA School of Public Health, the School of Medicine, as well as APLA Health and Sister Warriors Freedom Coalition from the Bay Area. And so you will be introduced to each of them in just a minute, but I just wanted to address a couple of housekeeping things as we get started. Gabe, can you go to the first slide, please? Next slide. So as I said, I am at the Policy Impact Core for CHIPTS, which is an NIMH-funded center at UCLA, and we focus on research related to HIV identification, prevention, and treatment services. And our specific core is interested in promoting policy-relevant research, training, and dissemination that addresses what are often comorbidities with HIV or people who are at higher risk for HIV, including things like substance use disorders and mental health issues, as well as barriers to things that support good health and structural factors that keep a lot of those negative systems in place. I'm also part of the next center that's co-sponsoring this event on the next slide, which is sponsored. Next slide. And that's the Southern California HIV AIDS Policy Research Center. And this center is funded by CHRP, the California HIV AIDS Research Program, and is specifically focused on supporting policy and research analyses that addressing emerging issues focused on HIV and related syndemics in our state. And the mission of the Policy Research Center is to critically evaluate how laws and policies impact Californians and propose innovative solutions with a focus on achieving health equity. If you take a look, and we'll share the websites for both centers at the end, you will see that there is research there and policy briefs that are very specific to, or that are specific to often very HIV-focused policies that maybe have HIV in the name or that are directly related to, very, very directly related to HIV. But as I said already, there are all sorts of social determinants of health that also impact people's risk, and many of those are on the ballot this year. And so we are glad to kind of step back in a way and speak to those, even though they may or may not have HIV in the title. And if you could just go to the next slide, where you can just kind of see an overview. We have things that include finally getting rid of language within our Constitution against same-sex marriage, as well as issues related to housing and criminal legal systems, and the way monies are spent that go into healthcare systems. So we will be getting into 5 of those specifically, but before we do, I just want to encourage everybody to answer the poll. We have about 85% participation, which is better than our voting rate. So we will, in our country, so we will hope that this gets up to 100 and that at least 80 or more % of the US population votes next month or before. And then at the end, there will be a short evaluation. So we ask that you also take the time to address that. Just to give you a brief, and I'm going to stop talking in just a moment, brief description of the format. Each of our panelists is going to speak for about 7 minutes after being introduced, and then we will have time for discussion and questions. And the person moderating our session today is Dr. Jack Needleman, who is at the UCLA Fielding School of Public Health. He chaired the Health Policy and Management Department and has done groundbreaking research over many years related to health services. And so I will let him finish the introduction of himself as well as our other panelists. Thank you.
Great. Thank you, Nina. The only thing I would add to what you did is I've got a long career of analyzing health policy and laws. I'm a one of the lead senior people on the California Health Benefit Review Program. And before I became a mid-career academic, I spent 17 years doing health policy research and analysis as a consultant in Washington, D.C., working with state governments and the federal government on health policy issues. So I'm excited to be here. I think we've got a lot of props on this year's ballot, and many of them touch on health, and many of them very specifically will have effects on the population who have HIV, and other health, and HIV often also in terms of other conditions that we probably won't discuss explicitly today, but clearly policies that affect the HIV population affect other populations, can affect other populations with chronic illness. So I'm looking forward to the panel. We've got a great panel that we're working with today. We've got 5 props that affect health. We're going to spend some time on 4 of them, 6, 33, 34, and 36. We're not going to spend very much time on Prop 35, which is a tax extension prop. What you've got, the current state of the law is we have the legislature passed an existing tax on managed healthcare insurance plans, much of which went back to funding with federal cost sharing Medi-Cal, some of which got diverted to other activities. That's scheduled to end, I believe, the year after next. And this prop would extend it by proposition rather than waiting for the legislature to enact the law extending it. It would also do some marginal shifts on which providers are eligible for funding under the law and which aren't. If you look at your guidebook to the election, you'll see there are no opponents to this. On the other hand, the LA Times and others have rejected it, have not endorsed it, and have encouraged voting no on it, partly because they think it's very fine tuning of the legislature of where of tax policy that you might expect the state legislature to extend, and the details of where the funding ought to go. And I think some props are like that, with small scale impacts on policy with specific interest groups that have a vested interest in seeing the prop move forward or not. I think the other props that we're going to be talking about today, though, have much bigger issues associated with them. And that's why we will be taking our time focused on those. I will be introducing each speaker in turn as we move forward. The first speaker is going to be Bert Cowgill, who is an associate professor in the Department of Health Policy and Management. He has taught health politics in the department and American health political institutions and healthcare policy. He's been actively involved in a number of state-specific initiatives on related to healthcare issues. He's worked on implementing regulations aligned with the implementation of Medicaid managed care, and partnered with CDC and state Medicaid agencies on improving childhood immunization rates. He does a lot of community partnered research, including work with unhoused Angelenos. And Bert's going to be focusing his comments on Propositions 33 and 34. And with that, Bert, let me turn it over to you.
Thanks, Jack. So appreciate being here today, and thank you for the invitation. So got a lot to cover, so look forward to your questions. So Prop 33, let's dive in. So this initiative is designed to repeal the Costa-Hawkins Housing Act of 1995, which prohibits rent control on single-family homes, including condominiums built after February 1, 1995. The law also prohibits rent control laws that mandate what a landlord can charge a tenant when they first move into a rentable unit. So repealing the Costa-Hawkins Act would allow city and county governments to limit rent on any type of housing unit in their jurisdiction and limit rent for first-time tenants. This would also mean any local laws currently preempted by the Costa-Hawkins Act would take effect upon its repeal. Lastly, initiative would add language to California Civil Code prohibiting the state from limiting the right of any city, county, or city and county to maintain, enact, or expand residential rent control. So this would not prohibit existing laws related to renters, though, such as our existing statewide limit on rent increases, which currently states that landlords cannot raise rent more than 10% or 5% plus the percent change in cost of living, whichever is lower over a 12-month period. So you can see here on the slide that the fiscal impact, there's a potential for reduction in state and local revenues in the high tens of millions of dollars per year over time, depending on how local governments decided to act in this area. Arguments for passing the initiative include keeping rents affordable to address housing insecurity and keeping rents affordable for new renters, expanding current rent control policies and programs to single-family homes and condominiums would expand options for renters under rent control policies and provide city and county governments more local control over rental costs in their communities. Arguments for not passing the initiative include landlords need rental increases to cover repairs for the aging nature of many of our rental units. Current rent control policies are not aimed at low-income renters, but benefit renters of all socioeconomic statuses. And more stringent rent control policies could discourage developers from building new housing, which in turn could raise rent on existing rental units as supply declines. To note, similar propositions have been on the ballot in California to repeal Costa-Hawkins in both 2018 and 2020, and neither had received enough votes to pass since it's coming around again this year. So just to reiterate, a yes vote on Prop 33 would repeal the Costa-Hawkins Rental Housing Act, allow rent control on single-family dwellings, and allow more control at the local level. A no vote would keep the current act in place. Okay, and I'm going to segue over to Prop 34. This one's a little bit more detailed. So if passed, Prop 34 would create a new category of entities called prescription drug price manipulators. And if an entity is classified as such, they would have to meet certain requirements annually to maintain their tax-exempt status and licensure as either a health insurance plan, a pharmacy, or a clinic. Now, these requirements would include them spending at least 98% of revenues from federal discount prescription drug programs on direct patient care, as well as not engaging in unprofessional conduct or conduct contrary to public health, welfare, or safety. The proposition also would permanently authorize the state to implement its Medi-Cal RX program, which was first established by the executive order in 2019 by Gavin Newsom. Now, the prescription drug price manipulator would be defined as an entity that would have to meet all of these criteria. They have to first participate in the federal 340B drug price discount program. They would have to own or have owned at least one license to operate a health insurance plan, pharmacy, or clinic in the state, or contract with Medi-Cal as a primary care case management organization, or with Medicare as a special needs plan. They also would have had to spend more than $100 million on purposes not related to direct patient care in a 10-year period, and own and operate or previously owned and operated one or more multifamily dwellings that have received a combined total of 50 state or local high violations. I know that's a lot. I'm more than happy to go through that more during the Q&A period. I also want to note that the California Legislative Analyst Office has indicated that very few entities would, as we know, would currently meet this definition. Now, in terms of fiscal impact, there would be increased costs to state government, potentially in the millions of dollars, to review entities' compliance with the measure and enforce the measure's provisions. These costs would be paid by fees created by the measure, and there would be uncertainty around fiscal impacts to state and local government health programs. It would depend on how affected entities responded to the measure's requirements. Support for the initiative would require entities defined by the measure to spend a majority of their revenues generated from savings from the drug discount program on direct patient care and prevent such entities from overcharging local governments for prescriptions. This would include using revenues on activities that address the social determinants of health, such as affordable housing. Opposition to the initiative would continue to allow entities to use revenues to advocate for and support services that address the social determinants of health, such as affordable housing. Want to note that funding for the federal 340B drug price discount program is funded through pharmaceutical companies and not direct taxpayer dollars. I point this out because some of the materials you may say describe this initiative as having an impact on taxpayer dollars. And lastly, the AIDS Healthcare Foundation is currently the primary entity that would be affected by this measure. So again, a yes vote would require healthcare providers that meet these criteria to spend 98% of the revenue generated from the savings directly on patient care. A no vote would leave us in the status quo.
Bert, thank you. Before we leave, just a real quick question. Do you have any sense on Prop 33, how many local governments are eager to move forward with rent control? How big would the response be if Prop 33 passed?
Great question, Jack. Yeah, and I did take a look sort of both around the state and nationally. Rent control, although we have it, locally here in our current apartments, et cetera, in California, is not as pervasive across the country. I think in terms of the number of cities that are willing to expand rent control to homes and condominiums would require some further discussions at the local level. Some of our more urban centers, I think, are looking to move forward on this more quickly than some of them are suburban and rural areas.
Okay. Great, thank you. We will have an opportunity to handle questions from the audience as we move forward. Question that has come up about the AIDS Health Care Foundation on Prop 34. And whether it would be most likely to be affecting them. We will come back to that when we get to the Q&A at the end. So two of the props, Prop 6 and 36, both relate to the criminal justice system. And we have to provide an introduction orientation to those props. We have April Grayson, who is a senior policy manager for the Sister Warriors Freedom Coalition. She is a formerly incarcerated person and, in her own words, has spent a lot of time in systems that harmed her rather than helping her escape cycles of abuse, exploitation, and the street economy. She's an advocate for children and youth caught in the pipelines to prison, working both as a policy advocate for criminal justice reform and with incarcerated women and children. And April, with that, we would love to get some perspective on what's happening with Props 6 and 36.
Thank you so much. So first, before I talk about Proposition 6, I would like to say that my team, with me as the lead, has been working to end slavery in California for the last 4 years. Proposition 6 was ACA 8, and prior to that, ACA 3. And so we have been really trying to get this through legislature, and we finally made it this year. And it is now Proposition 6, which you will see on your November ballot. And Proposition 6 will eliminate the constitutional provision allowing involuntary servitude for incarcerated people, which was called the End Slavery in California Act when it was ACA 8. And this will allow California the opportunity to vote to amend Article 1, Section 6 of the state constitution to prohibit slavery and involuntary servitude without exception. And so just a little bit of history. In 1865, Congress passed the 13th Amendment, which ended chattel slavery nationwide, but it still allowed for slavery to exist with an exception clause, which remains in the U.S. Constitution and currently our state constitution. Slavery did not end after the Civil War. It continued through the early 1940s. African Americans were leased out to plantation owners and manufacturers as cheap labor. And I just want to tell everybody as well, when they put the exception clause in the Constitution, it was for punishment of a crime. The only crime that was committed back in those days were people of color being outside after dark, people of color being on the opposite sides of on the same side of the street as Caucasian people, people of color traveling without notes. So every action that they were, as they were living their lives, they were arrested for being Black in public or Hispanic in public, Indigenous in public. And so this practice that we are now seeing play out in our carceral system with mass incarceration has been going on since the 1800s. It's embedded throughout our California system of incarceration today. And although no courts explicitly order forced labor at criminal sentencing, finding the opportunity in the Constitution is standard practice to force incarcerated people to perform labor. At the beginning of the pandemic, COVID-19, incarcerated workers were forced to make masks. They were forced to make hand sanitizers. They were forced to clean cells of people who were positive with COVID-19, and the protections were not given them. And had they declined the work, they would have lost their good time. They could have possibly went to board and received a rollover, which doesn't allow for them to get a yes to come home on their life sentence at the BPH hearing. And so they just had a lot of adverse effects in how people were allowed to program us inside of the institution. And so Proposition 6, a yes on Proposition 6 would allow people the consent and them the agency over their program if they choose to want to do higher education, if they want to do rehabilitative programming. If by chance they're sick that day and they cannot go to work, they won't be deemed a failure to program if they don't decide to show up to work that day. It gives them consent over programming. If we were to vote no on Proposition 6, it would still allow for slavery to remain in our Constitution, historically slavery to remain in our Constitution, and then it would also take people's agency over how they choose to rehabilitate themselves inside of our institutions. With Proposition 6, I will say again, people will now have the option to choose higher education as their work assignment. They will be able to prioritize rehabilitative classes over jobs like yard crew or the kitchen. And so currently people are beautifying the institutions versus pursuing their AAs or their MAs.
Great, thank you. And Prop 36?
I want to say one more thing into Prop 6. As of 2024, California is one of only 16 states that still has slavery in its constitution. As a progressive state, we're not as progressive as we think we are. Now, Proposition 36. So Proposition 36, if passed, would allow felony charges and increase sentences for certain drug and theft crimes. Proposition 36 would seek to roll back Proposition 47, one of our most progressive pieces of legislation that California has seen in the last 11 years. Proposition 47 reclassified minor felony offenses like shoplifting and drug possession to misdemeanors and meant the money saved on incarcerating people went back into our communities. So Proposition 6, which would undo 47, would take all the money that has been going into community housing, into mental health treatment centers, into rent stipends that people have been receiving from programs, and it would take all that money and give it back to law enforcement and incarcerating people. And so I just want to talk a little bit about Prop 47, just so we can understand what Prop 36 seeks to undo. Under Prop 47, we saw a 60% decrease in houselessness. We saw an 87% reduction in recidivism. We saw a 182% increase of employment. And so what Proposition 36 seeks to do is take people who are unhoused and criminalize people who are unhoused, criminalize people who need mental health treatment, criminalize people who are surviving based off of the poverty that we are watching people experience in California. And also Prop 36 is backed by law enforcement, right-wing prison lobbyists. That's who's backing Proposition 36. That is the money behind Proposition 36. If someone gets arrested for a low-level theft 3 or more times, including something as simple as returning a rental car late or selling a pizza, they could go to jail or prison for up to 3 years. Prop 36 will strip $100 million annually in funding for drug treatment, housing, and school-based programs, the very things proven to prevent crime in the first place. And as a person who spent over 17 years in the carceral system, there was a time when every single bed inside an institution was filled. Our day rooms were filled with double bunk beds. Our gyms were filled with double bunk beds, and the federal government had to step in to reduce the number of people incarcerated because of the conditions. Prop 36 will take us back to when we were living stacked on top of each other inside of these institutions.
April, thank you. So Bert has given us a quick introduction to Props 33 and 34, and April to Props 6 and 36. What we want to do in these with the last two presenters is try to look a little bit across the policies, across the props. We're going to start with Michael Lee, who's an assistant professor in the Department of Family Medicine, where he studies behavioral and biomedical treatment combinations to address substance use, HIV, and social adversity in diverse queer and trans communities. And I just noticed, Michael, I got your preposition wrong, and I apologize for that. Dr. Lee received their PhD in preventive medicine from the University of Southern California, and then completed postdoc at UCLA Center for Behavioral and Additional Medicine. He's going to focus on housing and HIV and how it might relate to across these different set of props.
Thank you. Can we jump it? All right. This is right here. I'm going to present some county data right now from Los Angeles County Public Health, and we find that some of these trends are pretty similar in other areas of California. These pictures are pretty self-explanatory right here. We see that the people who are newly diagnosed with HIV, a growing percentage of them are experiencing homelessness at the time of their new HIV diagnosis. So we're seeing right now that the housing crisis is also coinciding with the makeup of the people being diagnosed with HIV as time has gone by. And this has been a trend that's been moving upward, since 2012, probably at the start really was in 2016. On the other side of this too is that once people are living with HIV, if they are unstably housed, to their ability to stay retained in care and to stay virally suppressed also decreases by a pretty large percentage, as you can see by this bar chart in the top right corner here. I also want to, if we go to the next slide, get into kind of how it gets even more complicated from here. So housing instability coincides with substance use. In California, the primary drug that we see linked to HIV is methamphetamine use. And we also see that it's also linked to 1 in 3 new HIV infections among sexual minority men throughout the United States too. I've done some analyses of people in LA County, and it seems to be that if you are unstably housed, your risk of using methamphetamine in the future the odds increases by about 50%. On top of that, people who are, with histories of incarceration are also more likely to be unstably housed when they get out. Conversely, if you are unstably housed too, your risk of also becoming incarcerated also increases too. This is a vicious cycle that seems to happen with substance use too. So, the combination of housing instability and incarceration is driving the methamphetamine use epidemic that we have here in California, which in turn is also continuing to propel, forward HIV transmission. There's been efforts to integrate HIV care in this is not directly on this slide too, but there's been some efforts to improve HIV care among people who are incarcerated and also recently formally incarcerated. But I've been looking at data too, and it seems that the long-term effects of incarceration actually exacerbates risk of falling out of care and staying virally suppressed in people with HIV. What does this mean then if we're trying to end the HIV epidemic? Well, if methamphetamine use and housing instability and incarceration are decreasing people's abilities to stay virally suppressed and stay engaged in HIV care, we see that there's an additive effect too when you look at this purple line in this from this other study that I've done with the Los Angeles County Medical Care Coordination Program. If we want to end the HIV epidemic, and we consider that treatment as prevention where undetectable equals untransmittable, these are some barriers that are going to have to be overcome for us to increase the people who are undetectable, right, to levels that we're aiming for. So if we're aiming for 90 right now we're at 60, over including everybody, not just people who are unstably housed, people with meth use, people with histories of incarceration. So this is why too, a lot of the work that I do is around, providing wraparound services. I do a lot of community work too. So it's not just about the biomedical interventions out there, but also about providing auxiliary services and combined services that are, culturally informed and culturally congruent. So that's all I have here, and I'll stop right there.
Okay, thank you. We will be coming back to housing, partly because of Prop 33 and partly because of Prop 34 in a few minutes. One of the questions, Michael, that could be asked, and you can say, let's talk about it later, is whether the increasing homelessness among people living with HIV is due to people simply living longer because the drugs are as effective as they are. So that is that part of the problem, or is it just that the housing affordability and the economic circumstances of people living with HIV make housing prohibitively expensive for many people?
Yeah, I mean, I guess the way I think of it more is that, well, if we think about it, people who are unstably housed they're less likely to be in care and engage in care. So I think the benefit of the medical care system is not touching those people as much. I'm not sure if that's answering your question.
Okay.
Yeah. So instead, I'm kind of reversing the causation here, I guess, if that makes sense.
Great. Okay, I'm going to let you mull that over, and we'll come back to that in the round robin discussion towards the end. And to get us there, I want to give Sebastian a chance to do that. Sebastian's been given the challenging task of sort of reflecting across all the props on their impact on the population with HIV, living with HIV. Sebastian Perez is the state affairs specialist at the APLA Health, a federally qualified health center that specializes in LGBTQ plus care and HIV and STI testing, treatment, and prevention in Los Angeles County. He also leads in End the Epidemics, a statewide coalition that advocates budget and bill priorities that seek to end the syndemic of HIV, STIs, viral hepatitis, and overdose through harm reduction. So, Sebastian, it is yours.
Cool. Tengo nervios. Hi, my name is Sebastian Perez. Thanks for letting me chat. I guess I just want to start with some table setting for like the HIV landscape in this state, as far as I understand it, and why ETE takes a syndemic approach. So, in a nutshell, it's multi-pronged, it's intersectional, and it's an attempt to disrupt multiple social determinants of health that are typically exclusive of care for people who are most impacted by HIV and other related conditions. I have data on HIV that I'd like to mention. So 2023 data from Office of AIDS, still called that, right? There are about 142,000 people living with diagnosed HIV. So there's probably more, right? in California as of today. Trends are decreasing in new HIV infections in California. Great thing. But we have to talk about disparities, and these disparities are certainly class-based and most certainly race-based. So disparate in terms of new infections, they're decreasing more rapidly among white men. Great for them, right? Also, greater uptake in PrEP among white men. And the real disproportionate burden of HIV in particular is borne on men of color who have sex with men. And cisgender men, let me specify, cisgender men of color who have sex with men. So mostly Black men, mostly Latin, take your pick with the bracket letter, right? Men. The highest rates on HIV infection are in Black men, Black cisgender men, but the highest rates of new HIV infection are among Latin, X, E, A, etc. Men. And especially for Latinx men, that is trending upward. So there are still huge racial disparities in HIV that aren't being adequately addressed, despite biomedical interventions, despite programming and funding that, truth be told, isn't enough or adequate to really address this endemic, especially from a racial justice-based lens. So there's a lot, and I'll go through as quickly as I can just some of the different measures in the order in which they were presented. So Prop 35, it is a complex measure. They're all complex, right? And this is an example of what's disparagingly called ballot budgeting. But I do want to raise that Medi-Cal in California is overrepresented by Latinos again, right? About 42,000 people living with HIV are on Medi-Cal. And the idea with something like Prop 35 is to not only protect funding for Medi-Cal so that it can be spent on Medi-Cal services through provider rate reimbursements, et cetera, but it's also to make sure that the legislature and the executive branch don't have the means to willy-nilly sometimes, it feels, reuse those funds for other services. Some of the things that Prop 35 would also include are, aside from the provider reimbursement rates, is more funding for Medi-Cal RX. And, this is more conjecture at this point because there isn't implementation quite yet, right, assuming it passes. But it could save the state money on on pharmaceutical drugs that are expensive. PrEP is expensive, ARTs are expensive. Generic equivalents can be a good option for the state to really ramp up its efforts to get more PrEP to people. And that's a really complicated conversation, but that could be a positive benefit of Prop 35. In addition to increasing the provider pool in Medi-Cal by enticing more providers with higher reimbursement rates. That could mean more access for people living with diagnosed HIV. That could be more access people who are at risk for contracting HIV, like especially if they need access to PEP really quickly, for example. And also just more timeliness. And timeliness is crucial to achieving something like viral suppression, right? Adherence, making sure people get the care, medical care and attention that they deserve on time. Cool. So that's Prop 34. Sorry, 35. And this isn't a preemptive answer, but Prop 33 and 34, that's a B4 between AHF and the landlords. And, AHF, like Dr. Calgill has mentioned, AHF has introduced several ballot measures around affordable housing. They have a perception, I'll leave it at that. But there are a lot of benefits to anything that's going to assist with the housing affordability crisis, because the private market typically continues to fail in terms of producing enough adequate housing, and it's just a little bit greedy, right? When it comes to rent. So I do want to cite NASDAQ. I'm forgetting the acronym, but among individuals who are homeless or marginally housed, like people experiencing housing insecurity, right? The rates of HIV infection are up to 16 times higher than those who are stably housed. Additionally, the homeless men who have sex with men MSM population is 15 times more likely to delay HIV testing than stably housed MSM, much of aligned with what Dr. Lee mentioned a little bit earlier. So Rent stabilization could be very helpful, really complicated, right? Especially with the geography of what rent stabilization looks like in California, but could be really helpful. Prop 34, it's a get money out of politics measure, but only for AHF. So it's not actually a get money out of politics measure, you know. And I think the real consequence in terms of HIV to remember is that AHF is based in Los Angeles County. If the measure passes and, you know, there's everything in that measure is implemented, that means the revocation of licensure for AHF to practice, right? It has clinics, it has a small plan, but it has pharmacies, and all these things mean care for people diagnosed with HIV or people who are at risk for accessing HIV or for acquiring HIV. And, you know, AHF is huge. It has a lot of coin, but it also has a lot of services globally. So disrupting the headquarters can have repercussions for people around the world who depend on the medical care and treatment and biomedical interventions that are effective at preventing HIV and further transmission globally. And that's not, you know, so that's something to weigh in when making these decisions on ballot measure checking time. And I'm not a carceral girl quite yet. Like, I'm working on it slowly. But one thing that I want to tease out, because, you know, April was just so fantastic already, but also to mention from what I've learned over the past few weeks is that with the involuntary servitude / you know, slavery in a white supremacist institution like our carceral system in California, is that prisoners, people who are in prison do not have the option of when to work currently. So that could get in the way of people participating in things like cognitive behavioral interventions, which does mean substance use disorder treatment, and, you know, people getting different kinds of supportive services for dealing with and preventing things like overdose. Big crisis in California, right? And lastly, Prop 36. I hate this measure. I'm allowed to say that as someone who works for a nonprofit, I think, and we wrote it in our voter guide, which we can share. It's really just coming for people who are struggling with addiction and are unhoused. It's like the dicta around the measure just says as much, and its solution is not really to provide housing services. There's no plan in the measure. There's no implementation in the measure. It's just to jail people who are using drugs. And again, added to all these things, like jails and prisons are not the place to find adequate care for curing hepatitis C. You know, hepatitis C, like, even though people are treated for hep C in prisons and jails largely, they're also not, they're also really at risk for constant reinfection because of things like lack of clean needle access or, you know, and sometimes healthcare services are not that good in prison, right? Like, I think a friend and colleague that I respect a lot, Eric Henderson, mentioned that the state prison system was entered into a receivership in 1994 because it's just bad. I think this is something that April was alluding to. But it's a really evil measure. It's like also backed by like things like Target and Walmart and In-N-Out, and, you know, to quote Kate Moss, like, nothing is as good as freedom feels, you know, and that's a perversion. Excuse me,
Sebastian. Thank you. I want to make sure we have enough time for Q&A from the folks who are attending. So I'm going to shift to that. I want to remind the folks who are attending to use the Q&A function to ask your questions. We will pose them and move forward. One of the issues that came up, and Sebastian alluded to it, was the connection between Prop 33, the rent control initiative proposal, and Prop 34, the requiring some healthcare entities to who are receiving discounted drugs through the federal 304B program to hit certain spending targets. And one of the questions we received is that that seems to be targeting specifically the AIDS Healthcare Foundation. And Bert, I'm wondering, since you had those two props in your wheelhouse, if you could comment on the relationship between the two of them and what you think's going on there.
Absolutely. So thank you for this question. I have to admit, this was one I anticipated if you've been doing any of your homework on these propositions. So, I followed propositions for a long time, and even the title of Prop 34 with certain being the second term already tells me that you are identifying a certain, individual or entity that the proposition is looking at. So a little history here, and this was brought up as well. The AIDS Healthcare Foundation has been pushing to expand access to affordable housing. Proposition's been on the ballot in the past in California. A great resource for everyone on this webinar, if you want to learn more about these propositions and who's backing them, where the money is going, there's two websites. There's one called Ballotpedia, and there's another one called Open Secrets, and they will tell you who's been funding these propositions. So for someone who's been in healthcare for quite a while, and I took a look at the support for Proposition 34, you work your way down, you see there's almost $30 million have been spent. Almost all of that has been spent by the California Apartment Association. Okay, so it becomes very apparent who is supporting this bill. And given the way it was written, and that's kind of why I spent a little bit of time very explicitly going through the details of how a prescription drug price manipulator would be defined in California. Both my research and the California Legislative Analyst's Office really comes down to the AIDS Healthcare Foundation as being that certain entity. There may be others, but from my research, I haven't identified any at the moment. So, trying to be impartial here and really providing you with the facts, it is quite evident that this is a back and forth between the California Apartment Association pushing back against the AIDS Healthcare Foundation, who has been working to increase access to affordable housing.
Okay. We've been asked to provide a link to the voting guide, which we will do. Bert mentioned Ballotpedia, and I've got a link set up for that. And what was the other?
Open Secrets.
Open Secrets. Can you go into the Q&A, Bert, and add a link to Open Secrets?
Yep.
Appreciate that. Looking for
Question about 34. Is it true that AHF would be decertified if it was passed? Like my understanding, I thought it would be more just limit how they spend their 304.
Right. So
40B monies.
right. And this is sort of where, whether it's a bill or a law being passed, whether it's a proposition being passed, we then need to operationalize these laws through our regulatory processes, right? So depending on how this played out, the idea would be an entity at the state level would evaluate entities that met this definition and would determine whether or not their practices were in violation, and they could stand to lose their license. And the way it's written, this could be a health insurance plan, a pharmacy, and a clinic. And I think Sebastian nicely defined that the AIDS Healthcare Foundation kind of has its hand in all three of these. So if it was determined they had violated them, there may be an opportunity to change their ways and to use the funds directly 98% towards healthcare services. But this issue around violations in managing a housing unit would also have to come into play. So there's really a number of issues here. But the way I look at it and the way I interpret it, and with where the AIDS Healthcare Foundation has been using its resources in the past, there is a possibility that they lose their licensure. So yes.
I think one of the things is as people consider the props, we've been trying to focus through an HIV lens here today, and I think that's an important one. That sometimes the details of the props and the history are not in any of the formal materials and can be obscure. So I think that also applies to something like Prop 35, which on the surface looks like we want to make sure that the tax is extended, which you may not believe that the legislature is capable of doing that, but it also redirects some of those funds to very specific provider groups and sort of defunds some of the other provider groups that have been eligible for funding through the funds generated by that tax. Depending upon which providers you like and which providers you don't like, that might be positive, that might be negative, but it's important to think about sort of the history of these props, the sponsors and their intent, and what the actual effect will be, not just what is intended or the stated intent of the props. Those are some of the issues that one can see emerging. Want to come back to the issue of, because housing, Prop 33, is a particularly important one, and the issue of extending range control or not has been a very contentious one in the state. I'd like to come back to the question of thinking about whether how rent control issues particularly affect the population with HIV and other chronic illnesses. And I'm wondering if anybody on the panel would care to comment on that. Or comment further on that.
I'd love to hear from Michael and Sebastian, but kind of speaking more broadly from some of my other research I've done in this area, I've worked with the Medicaid population nationally for most of my career, and one of the things that's become quite clear to me, and over the years we've seen this anecdotally and now more through, a research and the way the data is playing out, that we can continue to spend money, whether it's HIV, AIDS, whether it's other chronic conditions. If you are unhoused, you're going to be cycling through emergency departments, and the costs of us treating you ineffectively through an emergency department are going to continue to skyrocket. I have now seen CEOs and CFOs of the major health insurance companies acknowledging we are better to invest in housing first and to get our patients housed and spend that money up front and get them well and save these turnstile emergency department payments that we're paying that aren't really getting the job done. So I'd love to hear from Sebastian or Michael more specifically about the HIV AIDS population and how this may play out.
I can offer, I guess, maybe two things aside from like what I mentioned about treatment adherence being easier to accomplish when you have stable housing. And again, the disparities are disproportionately born among LGBTQ folks, like transgender women of color are also just have these huge disparities of HIV acquisition in California, and transgender women of color also face a lot of just name the form of discrimination, right? Like employment discrimination and housing discrimination itself. And a lot of transgender women of color are extra vulnerable to housing insecurity still, right? Not just still, as if it were surprised, but unfortunately. In terms of the HOPWA program, it's been pretty much flat fund. Housing opportunities for people with AIDS, I think is what the acronym stands for. Funding's been flat for years at this point, and rent is still increasing. So whatever flat funding is available for rental assistance for people living with HIV is diminishing and more quickly for when assistance is available for housing. So those are two ways that I would offer for discussion.
Okay, other thoughts?
I can't really speak to the impact of directly the impact of rent control on the expansion of affordable housing. I will say that I absolutely support the expansion of affordable housing, because if you do not have a home, you're more likely to lose your medication. You're more likely to be exposed to violence. With the fact that a lot of people who are unsafely housed also use substance use as a survival tactic. There's research showing that people can use methamphetamine to stay alert in unsafe situations, especially among those who are unsafely housed. So, you know, if there's something that can get humans into shelter that is safe, you know, and reliable, and you know, I think that will be very, very important, I think, for us to make a dent in the HIV epidemic. Yeah, so that's you know, I don't really know how this will actually spill out in terms of how it interacts with other policies that are in place here. So yeah.
Okay, we're about 2 minutes from the formal end of the webinar. Ayako, how are we going to close this up? Are we going to invite the panelists to do final comments, or Nina to do final comments?
I'd like to jump in if I can. Hello, everyone. Ayako Miyashita Ochoa, she, her pronouns. Facilitator privilege is always a wonderful thing. The one thought that I had, I think that if folks are available to stay on, you're all welcome to. But the one thought I had was really lifting up, April, what you had to say in your piece, talking about voter backlash, right? We are all here not because, you know, obviously for us, our source of funding and who we are and what perch we're standing on makes it so that we're not here to take any position on any propositions. We're here to provide educational information. But that said, the thing that really strikes me is this question of how are we using evidence, information, data in a way that is accurate to inform our decision making. And I feel that the piece that you leaned on that was really striking to me personally was this idea that, you know, with 36, the data are not showing what we think they're showing. And so just as a sort of a last piece, if everyone will just bear with me for a moment, I'd love April, if you might have a few words to say about that.
Thank you. So I will say since 1995 that crime has been on the decrease. We had a small uptick in during the pandemic, but it went right back down. And they're not addressing that. They're not saying that crime is not high. They're using I think like the smash and grabs and like the bipping in the Bay to make the public and people believe that we are living in scary times, but that's not the case. People are benefiting from these resources and they are not returning back to prison. Crime is at a low, and we need to keep making sure to keep it that way by allowing the prisons, not the prisons, allowing the organizations, the grassroots organizations who are providing the services and the experts of keeping people safe, helping them navigate through their substance abuse as well as their houselessness, and making sure that they have the funds to keep pouring into people so that we can keep crime low the way it has been.
Thank you so much. So we are out of time. Again, like I said, we're going to stay on because we're like that. I'm going to go ahead and launch our evaluation survey. For those of you that are still with us, thank you so much for being with us.
And for those, I just want to note for those who asked about the voting guide link, the Open Secrets link, and the Ballotpedia link are all now available on the Q&A link on the webinar. And if you can't get them for some reason, just drop Nina, Ayako, or me an email, and we will get them for you.
We'll definitely be sharing resources afterwards, so y'all can expect an email from us for certain. I just want to say, as sort of our parting words here, I'd love for you all to check us out online. I'd love for you all to join us on social media, and I'd love for you all to just recognize something that I always like to do, which is that our university sits on stolen land. We want to acknowledge the Gabrielino and Tongva peoples for as the traditional land caretakers for giving us this privilege to speak tonight. And we so thank all the folks that are providing their underpaid and unpaid labor to make that happen. So we wish you all a very good night. We will stay on because we are like that. And we look forward to to sharing resources after our session today. So I will close officially with that, and then we'll continue the conversation with Michael. Michael,
Oh, I wanted to
we have
add,
been waiting patiently. Are you
yeah,
good? All
I wanted
right.
to address your question too, because you're talking about evidence, and I can see very, very clearly that incarceration increases risk of overdose. After people are released, it is not doing anything to help the substance use epidemic, and I can tell you that from evidence there. So that's my own that's just what the evidence shows. This is very clear longitudinal research. This is true not just in the United States, but in other countries as well. So
Yeah, thank you so much. I mean, the danger of incarceration is one that, like, I think I know, Nina, you study this a lot, and I know there are other folks that know from lived experience that this is the case, that the dangers of incarceration don't begin with being placed in confinement. They also come with coming out of confinement, and then what? And of course, all those factors, April, that you touch on are just, so critical in understanding how is it that we as a community can become healthier and stronger, and live with wellness, and not just the absence of illness. So on that note, we'll again officially close and just say thank you so much to our panelists for being with us today.
You're here.